But now I would like to introduce our speaker, Johanne Morne. She is the director of the New York State Department of Health AIDS Institute. Johanne, you may now have the floor.
Good afternoon, everyone. It is my pleasure to join you, Samantha, to yourself and the other innovative individuals who have put on this conference. I want to say thank you. The opportunity for us to all gather collectively, even virtually, to have a discussion about health equity, health justice, and the opportunities that we have to not only seek but create to impact change in our communities is so essential. So thank you for this opportunity. The slide that you see here is a collage of different images. And for myself, working in public health certainly speaks to the past year or 10 months for myself, as well as many other colleagues. What you see to the left are the images of the state's response as it relates to COVID-19, recognizing New York tough, recognizing the multiple phases that our state has gone through as it relates to the pandemic. On the right, you see the visuals that speak to ending the epidemic. A key initiative that New York State had started in 2013 that looks to significantly decrease HIV diagnosis. In both scenarios of response, what you see is a partnership between government and community. And certainly, I think, for those who may have background in HIV and AIDS, what you recognize when you hear about the different steps that are taken in responding to COVID-19 is a very familiar pattern of steps that have proven to be successful in ending other public health epidemics, such as HIV. Next slide. So the image that you see here is a reflection of, HIV prevalence. But what this slide represents is HIV prevalence. This is indicated by the last known residence of individuals, and this is 2019 data. For the purpose of my presentation, I'm going to be providing data that speaks to the outcomes of 2019. And in talking about health equity and health justice will come from a perspective of HIV across New York State. So there are about 107,000 individuals living with diagnosed HIV in our state, again, as of December 2019. Based on the last known residents, 78% of those individuals reside within New York City, while the remaining individuals reside in rest of state, all those areas outside of New York City. Of the 23,000 estimated individuals living with diagnosed HIV, we know that 24% of individuals are in Nassau and Suffolk County, followed by the lower Hudson's area, Albany and Buffalo at 13%, and Binghamton at 2%. So I provide you those data points because I think it's significant to understand where within our state we continue to see the highest number of individuals who are living with diagnosed HIV, because it speaks to our opportunities to ensure that we at the same time have a level of services that are adequate to meet people's needs. Next slide. So the slide here speaks to populations and communities who continue to be disproportionately impacted. While in my presentation, I will speak to some of the successes that we have seen since the early days of HIV reached New York State to today. It is very important to understand the nuances of the data that's being presented, not only by myself, but in general. There are particular communities and individuals, particularly Black and Brown, who are disproportionately affected by HIV and continue to be so in spite of the many advances that we've made, both in prevention as well as treatment. In 2019, 36% of new HIV diagnoses, estimating about 2,300, are among persons between the age of 25 to 34. The age group represented the largest number of new diagnoses every year for the past 10 years. So, key point, what are we doing to ensure that our messaging is reflective and engaging to individuals in those age categories? 54% of newly diagnosed HIV are among individuals with a history of male-to-male sexual contact, including men who identify as gay, bisexual, or other men who have sex with men. The risk here also represented the largest number of new diagnoses for the past 10 years. 80% of new diagnoses are among individuals who are assigned as a male at the time of birth, and Black and Hispanic individuals account for 78% of persons who are newly diagnosed. So while the work that we have done across New York State has allowed for continued reductions as in Black and Brown communities, still the level of diagnosis of new HIV diagnosis is primarily among individuals who are Black and Brown. So when we talk about health equity and we talk about health justice, it is so significant and important to remember that nuance will continue. The slide here represents new HIV diagnoses. Again, and speaking of ending the epidemic across New York State, in which we look to significantly reduce diagnoses, we had set the goal of reducing the number of new diagnoses by 55%. So some of the high points that we can take from here, we see a 4% decrease in 2018 as compared to 2019. Since 2014, we have seen a decrease of new diagnoses about 31%. And we continue for multiple years now to have achieved the elimination of mother-to-child transmission. For those of you who have been doing public health work, you will remember that in the early days of HIV, we were seeing hundreds of infants being born with HIV. And so since that time, we have taken specific policy steps, but more importantly, provided education and expectation to our providers to ensure that we move to a place where we are now of eliminating mother-to-child transmission. And so, even with the numbers that I provided that show a continued reduction in the number of overall diagnoses, it is significant that we understand those numbers according to race and ethnicity. The slide that you see here represents data for 2019. HIV diagnoses, which is reflected in the blue line, new diagnoses reflected in the gray bars, are a reflection of race and ethnicity. Outside of the count of diagnosis, another way in which we look at data is by rate, and that rate is considered per 100,000 individuals. So for example, for every 100,000 individuals who identify as Black living in New York State in 2019, 33 individuals were newly diagnosed with HIV. This is the highest rate among race and ethnicity groups. So the slide that you see here shows a 10-year trend of persons newly diagnosed with HIV. This includes a reflection of individuals who identify as multi-race, Asian Pacific Islander, and Native American across our state. In an effort to ensure that all communities, regardless of the numbers, so sometimes when you're talking about surveillance data, it will be said that a number or a data point has not been produced because the number is too small. However, when you're speaking of public health, in my opinion, and you're speaking of HIV diagnosis, certainly it would be the best practice to include all communities and individuals impacted, regardless of how small the number is. It allows us the opportunity to engage in prevention activities so that we can do the best possible intervention to ensure that those numbers do not increase. I'm going to continue. So we continue within the AIDS Institute to look at all race and ethnic communities so that we can look at the areas of health disparity. I think I've suggested, and I've said quite clearly actually, more than once during this presentation, that when we look at Black and Brown community, we see such a distinct disparity. So it leaves us to in a position where we have to think about what are the social determinants of health? What are the social and health supports that are missing? And what are the key steps that we need to take to ensure that in looking at the entire continuum of our response, that we are prioritizing communities who are not necessarily seeing the same advances, whether it be in HIV or other public health areas that other communities are. So the slide that you have here shows newly diagnosed individuals with a history of male-to-male sexual contact. So that describes men who have sex with men who identify as gay, bisexual, or other men. And this is by residents at diagnosis as well as race and ethnicity. Overall in New York State, non-Hispanic, Black, as well as Hispanic individuals account for a majority of the new diagnosis among the MSM population. We do see differences between New York City and rest of state when broken down by region and residence. The images of this slide may look familiar in that you saw it in just a few minutes ago. However, this slide speaks specifically to sexually transmitted infections. So 54% of STIs are diagnosed among people younger than 26 years of age. 93% of primary and secondary syphilis diagnoses are among males. 84% of these male diagnoses are among individuals or men who identify as gay, bisexual, or other men who have sex with men. Hispanic, and Native American individuals also disproportionately impacted by STIs. So I'm sure if you're watching the media as it relates to the COVID pandemic, you hear a lot of the discussion around the disparities that have been seen, particularly among individuals in Black and Brown communities. I think for myself, as I listened to the media and I listened to some of the other reports, what caught me off guard was a level of surprise. Working in public health, I think that we understand that certainly the communities that are disproportionately impacted are going to be disproportionately impacted across all health issues, because it's not a matter of the specific public health crisis that we may be engaged in or focused on. What matters is the ongoing, consistent, persistent lack of ability to address the social determinants of health that impact people's ability to access, be able to engage, and to sustain ongoing care and treatment. So what you see in this slide are individuals with the greatest burden of STIs. And similar to the COVID-19 pandemic, the largest impact of STIs have disproportionately affected people in the Black, Hispanic, non-Hispanic, and Hispanic communities. These individuals are 5 times more burdened by STI as compared to white non-Hispanic individuals. So I had just commented as it related to COVID-19 in New York State. Please note that the data that you see here is from January 11th, the last time in which I reviewed the dashboard. All of this information, particularly as it relates to COVID, is available on the New York State Department of Health website. But what you see here are each of the steps, again, very familiar to us as it relates to the response that has been developed over time to HIV, testing, diagnosis, hospitalization, and unfortunately, for too many, deaths. New York State, as it was for HIV, was the epicenter for COVID-19. As of January 11th, we see that we have 27+ million New Yorkers who have tested. And again, I point to the number of individuals whose lives have been lost. Since this pandemic began last March, significant steps have been taken in order to respond and try to get both our state as well as our nation and across the globe to a place where we are not in a crisis mode, speaking of a pandemic, but rather in a sustainable mode, treating COVID-19 as a health issue, as we have been able to do with many other health concerns that have happened over the years, including HIV. In order to do that, though, we have to ensure that the same level of access, the same prioritization of community, and the same ability to engage individuals is across all communities. It is not satisfactory to say that individuals have access to testing, as an example, whether it be related to COVID or HIV or otherwise, because there is a center or a site in a community that provides that testing. What we have to do is continue that dialogue to ensure that the center or the place in the community that provides testing is an environment that is engaging and welcoming to the individuals who would seek care in those settings or testing in those settings, from the point of entry to the point of exit. This speaks to how we create opportunities of justice and equity, creating environments of care that are representative of the people who are using those services, that are representative of the individuals and their cultural traditions, and that are spaces that can be safe without judgment and without stigma. And I think it's safe to say through all of our conversations that this is an amazing challenge for so many. But in fact, if we were to sit down and comprehensively work to coordinate systems that were able to be reflective, be equal, engage communities, we would see significant differences in the numbers that we're talking about. Whether it's COVID, whether it's HIV, whether it's STIs, hepatitis C, cancer, the list can go on. And I also want to make the point that when we have these discussions, we need to not only consider the physical health of the individuals we're looking to care for and serve, we have to consider all the aspects of health that an individual is made up of, including our mental health. So making the connection again to the commonalities with HIV and COVID-19, we are studying individuals who have been co-infected to better understand the impact of COVID-19 for individuals living with diagnosed HIV. What we have seen are the similarities between HIV and COVID-19 in terms of, again, the individuals in the populations who have been disproportionately impacted. The New York State Plan to End AIDS, which we refer to as the Ending the Epidemic Blueprint, notes that, and this is significant, demographics do not in and of themselves place individuals at risk. It is not skin color, ethnicity, identity, gender, or age that result in infections. Rather, it is the contextual factors such as poor healthcare, poverty, inequality, and geographic disadvantages that amplify one's risk. The principle applies across the board, as I've said before, to all elements of health and care. So I had asked to put this slide in, recognizing that certainly through the course of the conversations you've already engaged in today, I'm sure you've reviewed definitions. And while the definitions may have particular nuances in them, depending on who the speaker is, certainly I think that there are themes and there are consistencies that address health inequities, health disparities, and the social determinants of health. The images that you see here are available on our New York State Department of Health website. We have taken tremendous steps in the AIDS Institute and across the Department of Health to ensure that equity is at the center of all of the interventions and work that we do. The AIDS Institute, while by name certainly is most associated with HIV, also includes within its priorities sexually transmitted infections, viral hepatitis, drug user health and wellness, and LGBT health and wellness. And in each of these priority communities, the conversations of inequity, disparity, and social determinants of health absolutely are a framework to what we must take into consideration, what we must prioritize when thinking about how we develop funding applications as well as resource allocation, and how we continue to develop systems that also, with our partner organizations, with our partners in the community, prioritize each of these areas in order for us to have better and improved health outcomes. One of the opportunities that I've had in participating in the COVID response for New York State is to work with the New York State Vaccine Equity Task Force. The task force actually just kicked off, if you will, about 2 weeks ago, and it has been a tremendous conversation in looking at the opportunities of health equity, social equity for the distribution of vaccines. The images that you see here represent the 4 chairs of this committee, and also a slide that speaks to New York State will mandate social equity distribution by not only the local health departments, but all of the different areas in which vaccination is is accessible. What you see to the left here are basic summaries as to what the task force is charged to do and how they will work to identify and break down the barriers as it relates to vaccine within the communities of individuals who are Black and Brown, of individuals who most often have disparate outcomes, right? And I go back to some of the elements that I spoke of before. Individuals who live in communities of poverty, individuals who are seeking support systems in different ways, that those support systems have a way in which they can help to triage and provide access to individuals for the COVID-19 vaccine. So equity and the distribution of the vaccines has been one of the key priorities. I am honored to be part of this work related to the task force, and I am looking forward to the outcome of the recommendations from the task force as they continue to move forward in their deliberation and in their significant work to ensure access across all communities of our state. Our goal, obviously, as we have these discussions, is to achieve health equity, where no one is limited in achieving good health because of their social position or the social determinants of health that they may be experiencing. I think that certainly my comments so far have indicated that, you know, health equity, and even in these slides, a lot of times I think that when we talk about health and we talk about public health, we tend to claim words, and we start using them all the time. You know, so for a long time, everyone wanted to talk about cultural competence, and then everyone wanted to say, well, it's not competence. Let's talk about cultural responsiveness. And so now everyone's talking about health equity. And so while I applaud the efforts, I'm always so interested when I see the job notices of all of the new health equity and diversity positions, high-level senior positions that all of the companies are creating. And here is my thought on that. That is a right step. I agree, but that is not the only step. And what I'd love to see across all sectors of our community and our state is that the conversation of health equity isn't just a bullet point, but it's an action. And it's an action in looking at all of the systems that have contributed to the challenges that people experience, the structural racism, the stigma, the discrimination, the lack of opportunity equal across all communities. So if there were any challenge or call to action that I would make, it would be about ensuring within any of the circles or facilities or work that you do that health equity not become a bullet on a slide, but become an action and a core central feature of how everything that you develop is brought to fruition. And so here are some of the images. There are many, you will see many, as we work to educate and build awareness around COVID-19 and the vaccination. That's what these images are here. The creativity will be key. The opportunity and the actual fulfillment of creating images that are representative of community, that look like me, that look like you, that look like the individuals that we're speaking of that we want to ensure we reach, will be key. And most importantly, making sure that there is language access. Another key point of health justice, health equity, social equity is making sure that people don't have to conform to what we create, but that we create what people actually need. And if education and awareness is one of the pillars and key to the reduction of the transmission of COVID-19, the reduction of the transmission of HIV, STIs, the increase in literacy across all of these different conversations, then we have to take very intentional, persistent steps. And I think that, you know, right here, you have a very basic, plain campaign that can appeal to anyone. And we need to build on that to continue to look at the communities that we want to reach. And I see in the chat, there was a comment as it related to transportation. transportation is key. And so if we use COVID-19 as an example, I think that one of the things, or even if we use HIV testing, so let's go to prior to the appearance of COVID in our communities. HIV testing it would never have been reachable or successful had it only been accessible behind closed doors. Early on, looking to grassroots methods, looking to the utilization and the experience and lived experience of peers, looking to the opportunities to bring the tools into community, that's what made HIV testing accessible. And it's interesting, more recently, particularly in the light of COVID, I've heard more and more people talking about going back to grassroots. And I have an appreciation for that. Certainly our systems, we are fortunate, we continue to advance in technology. But grassroots in the community, boots on the ground, is key to our success. As it relates to transportation, when you think about where you place access for people, it's not about only being, let's say, on a bus line, but it is about considering how will people access our services. Maybe it is a bus line, but is the location of these sites in a place that is accessible to all, that is accessible by multiple different ways of transportation? I know a lot of times if you live in upstate New York, as I do, we tend to look at New York City and think, oh, transportation's easier in New York City. There's a whole subway system. But when you go to New York City and you understand how use of that subway system works, you recognize that there are a number of different barriers for individuals who may not be as physically able, for individuals who may not have the money to be able to take a subway, and for individuals who recognize that in order to get from A to B, it could take over an hour. That's why it's so important to make sure that when we think about how we are pushing out our initiatives, we think about how we create the space and the paths for people to be able to get there. Oh, and so the next slide offers you my contact information. What I can say in closing is this. I've been very fortunate in my career. I've always worked in public health. In those opportunities, I've met so many people with lived experience who helped me understand that they absolutely, positively, without a doubt, knew better than me. And that's what helped me grow. If we want to seek justice, if we want to create paths to equity, then we need to be honest in our dialogue. We need to address the historical barriers and challenges that people have experienced. We need to ensure that the voice of people who are impacted by the decisions we make are at the table. And we need to look at every system that we have to determine what we can do to impact change as it relates to race, ethnicity, age, every single social dynamic. When we talk about social determinants of health, it's not just a group of things. It's the manner in which each individual on a daily basis lives and has to consider how they will take care and achieve for themselves. So I appreciate that some of the most horrific events that we've seen over the last, I don't want to say the last year, because for many of us, we've been seeing these images for a very long time. It's just that the more recent events, Breonna Taylor, George Floyd, so many others, have allowed for a dialogue that couldn't be denied that we have to build on the opportunities. The doors opened in some of that discussion. And what we have to do is take advantage of the ability for us to grow and look at the challenges and the barriers that we have in our administrations, in our systems, and across every avenue that relates to our healthcare and social supports. So I say all that with the understanding that so many of you that are here at this conference today, you're here because you're already invested. You've already done a lot of this work, and you are continuing to do the work. I hope what you get from today's conference is an opportunity to know that everything that you're doing is heading in the right direction, and that at times when it seems so frustrating, that's when we have to persist even harder. So I'll stop there. I would welcome any questions or any comments that you would like to share. I thank you for your work, and I thank you especially for making such a difference in so many people's lives.
Thank you so much, Joanne. That was a wonderful presentation and some very powerful words at your closing. Now I'd like to introduce my chat monitor, Sydney, who again is also the founder of this conference, so she's incredible. She will be taking questions, and we have a good 16 minutes for questions.
Samantha, I apologize. I've lost my visual on the screen, but if you can hear me, then that's fine.
Yeah, we can hear you.
Okay.
Hi, everyone. I'm going to start with a question from Valentina.
Hi. So I'm better at phrasing my things with my voice than putting them in chat. So my question is, we know that obviously things like HIV and COVID disproportionately affect certain communities. And so do you feel like we should be spending our resources and using our resources disproportionately if we know there's certain communities that should get more vaccines because there's more people in that community that are getting them, even if they're not 65, or if we know that Black men need to be getting more resources about AIDS education, that we should actually not be looking for equity, but we should be looking for getting more to those communities that need it more, instead of giving a blanket approach to everybody.
Sure. So thank you for that. I think that certainly let's talk about, for example, if you have a funding application that would offer an initiative within, across the state. The reason why data and individuals with lived experience being offered the opportunity and given the opportunity that they should have to provide input into how things are developed is because you have to think about, to your point, where is the need the greatest? And so it makes sense that when you're looking at the allocation of resources, that you would give more resources to areas with greater need. That's what makes sense. That said, I think that some of the recent public health challenges, particularly if you look at COVID, number one, what we know is that we don't have an adequate supply to meet anyone's need, I would say at this point. We're continuing to build in that. But yes, what ultimately we want to do is ensure that each community is based on what the presenting need is able to have adequate allocation. The challenge comes in when you have limited resources. And so then you have to sit back at the table and discuss, how do you create those priority groups, and or how do you create additional options as to how we could respond to whatever the presenting need may be.
Thank you so much for that response. I want to highlight a comment from Simone Seward in the chat and ask if you could expand on it a little bit. She wrote that oftentimes minoritized people can be brought to the table for representation, but just in a token role. And she says they're still silenced because the people who brought them there are just checking a box. Could you expand on what meaningful community engagement looks like?
Absolutely. And nothing's more frustrating than knowing that you've invested your time into something, into a plan, into a discussion, only to find that the input that you provided wasn't considered. So I couldn't agree with you more, and I do agree with you. It isn't just about the seat at the table. It is about having the meaningful input and the recognition that what you're bringing to the table matters in the discussion and the outcome. One of the things that I always suggest to individuals who are, considering joining a discussion or a group is I suggest to them from the beginning, ask up front, what is the intention of inviting me to this discussion, and how are decisions going to be made? Number one. Number two, I think that when you are in the discussion and you're finding that you're not being heard, it's important to say that up front and loud so people understand that that has to also be part of the discussion. I think certainly that, yes, I want to say, those who are creating the spaces need to understand how significant it is to take and utilize the information that's being shared. But at the same time, when that's not there is a point where you demand that space. I also think that applies to the issue of data collection. Oftentimes when I see something coming across my desk to say, like, we want to do this research, we want to do a survey, we want to get this data, my first question is, for what purpose? Because if it's a matter of collecting the numbers for the sake of collecting numbers, then let's not do that. Let's not do that to ourselves or to the people that we're asking to participate. But if it's for the purpose of a greater understanding of something that actually will result in some type of action forward, then that makes sense to me.
Those are great points, a lot to learn from in there. Our next question is from Danya. How do changing administrations and policies affect the work that you do? How do you work around that?
Sure. So obviously working for a government agency, there is always change, and certainly as terms come to an end, there's always a possibility of change. I think what's important is that, and one of the many things that I'm proud of as it relates to the State Department of Health AIDS Institute, but the core of the AIDS Institute is just that. We are very clear on the mission, the vision, and our values. We are very clear as far as the communities that we serve and how we can provide access to services. And so even in the midst of a changing administration, that base, that foundation, and that partnership with community members is what allows us to continue to be successful, regardless of who's sitting in what seat. That said, I think it's also important that you, as there are changes within your environments, that you learn about the people who are now in your space, and you understand what some of the thinking is, what some of the policy or politics may be, and you make some decisions based on that. You look to the opportunities to have conversation about the importance of what it is you're doing, but you also learn about the others around you so that you can be prepared.
I think that values-driven approach also applies to some of the other institutions that we work in, not just government agencies, but also hospitals and schools. We have our own administrations that we're working with, and having core values keeps us consistent over administration changes.
Absolutely.
Next question is from Karina. For those of us who are students and entering the healthcare field soon, what advice do you have for us to address major healthcare disparities facing Black and Indigenous people of color? How and what actions do we need to take?
Mm-hmm. So in my experience, it's about consistency and persistency, right? And it's making sure that in the environments that you choose to go and work in, that you're constantly asking the questions. For example, things like, you see a sign or you see educational material that's being handed out to patients. asking the question of, well, where are the translated versions, right? Making the point always that there are so many things from the point of entry to the point of exit for someone's experience to be able to feel that they matter and they're heard. And so, finding your space in your work environment where hopefully it's not only you, it's a collective voice, but there are conversations about how do we acknowledge that we serve a diverse group of people? How do we pay respect to that diverse group of people? How do we create and look at, again, and I know I've said this like 4 times, but I'm really, really clear about the impact on people's experience and their spirit from the time they enter an environment to the time they leave, and whether or not they feel recognized, heard, and respected during their time there. So, one of the things and opportunities you have is that as you newly come into environments, you have a lens that looks different than people who may have been there for periods of time. Use that lens and offer others the opportunity to see what you see. And where there are deficits or where there are opportunities to build on creating space that is more responsive and caring to people, consider that part of your responsibility.
Yeah, thank you so much for that response. Throughout your talk, I was wondering about the relationship between infectious disease epidemics and incarceration, especially during COVID-19. We've seen public health experts recommend vaccination for people who are incarcerated, and negative public opinion has kind of encouraged politicians to backtrack on that and prevent people who are incarcerated from getting the preventive care that they need. Could you talk a bit about how we can advocate for incarcerated people as well as culturally stigmatized people in general?
Sure. So in speaking of individuals who are incarcerated, the advocacy there and the idea of coming from a place of compassion is really key. I think that all too often, yes, the stigma and discrimination that is experienced by people who not only are incarcerated, but have a history of incarceration is tremendous. At the AIDS Institute, we have an initiative, it's called the Criminal Justice Initiative. It is a partnership with funded providers in the community, and their role is to provide sexual health information for individuals who are incarcerated, access to HIV testing, and to partner with the prisoner jail facilities, the staff there, to be able to provide education and awareness as it relates to those health areas. In addition to that, the Criminal Justice Initiative is responsible for helping individuals who are returning to the community because it's significant. So what we want to do is address, what are the, again, social determinants of health that individuals who are returning to the community after being incarcerated, what are the immediate needs that they have, and addressing those needs in an effort to, number one, maintain whatever health supports have been initiated while incarcerated, and 2, helping to reduce the rates of recidivism. And this is significant. I think that the opportunities that we have for individuals who are incarcerated to provide them with the levels of support have proven to be effective and really are essential for a number of different reasons.
Thank you so much. Are there any other questions from the audience?
I believe there was a question as far as how are you using the data. So if we were to speak about surveillance data related to HIV as an example, that data is what helps to inform us as far as funding allocations, as far as where, to the question earlier, where additional supports are needed. It also helps us understand, as I spoke of here, the different demographics as to where we need to prioritize and in the development of our educational and other materials, as well as help us understand in general, where are the areas that we are making significant advancements in, and where are the areas that we still need to focus. So the use of data is key. It's the effective use of data, one, the transparency of data and the outcomes, two, and the ability to make sure that we continue to look at the outcomes of what we've created as a result of collecting that data. Change is hard for people. I think we all know that. We've seen that certainly over the last 10 months. That said, at certain points, you have to ask yourself, as it relates to data, why are we continuing to collect it? What made sense 10 years ago may or may not make sense today.
Thank you so much, Joanne, for this incredible presentation. I really enjoyed it, and I'm so glad to have met you this year through my mom. We can answer one more question. If you want to send it in the chat real quick, we do have another minute.
My question is about the data or the algorithm that is used to collect the data on HIV. How long is it? The one that was developed in the 80s?
Hi. So I think I understood the question, and you're asking, are we using the same methodology for the data collection, the surveillance data collection today that was being used in the early days of HIV? Is that correct? Okay, so let's assume if that's the question. No, the methodology has changed over time, mostly because of the advancements we made with our technology. That said, much of the surveillance data that we collect uses methodology and formula that is developed by the Centers for Disease Control and Prevention, the CDC. So in that regard, regardless of what state you sit in across the US, the methodology is the same. Which is why the CDC is able then to make comparison among states and jurisdictions to see where certainly the highest numbers as far as individuals who are being diagnosed are, and again, able to make decisions as it relates to funding allocation and other efforts.
Thank you all for joining the session. Thank you so much, Joanne. This was incredible.
Thank you. And please, anyone with questions or anything, just feel free to reach out to me. That's why we're here. Take care, everyone. Stay safe.